Okay, thank you. I will see you on the day. This is a pre-recorded discussion about learning disabilities and dementia. So thank you for joining me on this particular session. So briefly, just to introduce you to who I am. My name is Chris Knifton, and by background, I'm an associate professor at De Montfort University, and I specialise in neurocognitive and neurodevelopmental care. So that includes both learning disability and, interestingly, dementia. Professionally, I trained as a learning disability nurse and as a social worker, and I'm also an Admiral nurse with Dementia UK. And one of the reasons why I'm quite interested in the association between learning disability and dementia is because in my own family, I have a brother. Well, I had a brother. Sadly, he passed away a couple of years ago. But my brother had quite severe learning disabilities. And I myself, although I don't have an LD as such, I also have autism. So I'm quite interested in the connection between learning disability and dementia from both professional and, I guess, family relationship angles too. So that's me. And the subject of the talk today will be about learning disabilities and dementia. And I hope you get something from this talk. So to begin with, I wasn't quite sure what people knew about LD as opposed to dementia. So just a couple of slides really to get us involved in those discussions about what we mean by learning disability and how common it is. So when I use the initials LD, that just stands for learning disability. And we know when we say roughly, we can only say roughly there are about 1.5 million people with an LD in the UK. What is interesting is that the numbers of people with dementia and LD do vary when we're starting to say how many of those people actually have dementia. It's hard to say because the way people assess and diagnose is not usually straightforward, and sometimes it can be forgotten. So a lot of it is down to the quality of assessment and the availability of diagnoses. And sadly as well, there are cases of dementia which are left undiagnosed, and also cases of dementia which aren't actually dementia. There are often something, call it a differential diagnosis, but they've gone down the dementia route without considering other conditions. And I'll look more onto that later on in the slides. But we do tend to say, on average, 1 in every 5 people with learning disability are likely to develop dementia. So it is quite common. And in fact, it's the risk of dementia is higher in the LD population than it is in the general population. Another interesting fact, I guess, is the onset of dementia is often much earlier in learning disability. And for people with Down syndrome, which is quite a large sector of the LD population, they do have an increased risk of Alzheimer's disease. And those of you familiar with dementia itself as a topic will know that dementia is a most commonest cause of Alzheimer's disease is the most commonest cause of dementia that we have. So this association between Down syndrome and Alzheimer's disease, Down syndrome and dementia, is a very notable one. So a lot of people, or you may ask on the day in your comments, what is the connection between Down syndrome and Alzheimer's? So what I've tried to do is to break down the science as basically as I can, because we're such a broad audience. So this next slide, I shall call it the science bit, the link between Down syndrome and dementia, and why dementia, namely Alzheimer's disease, is so prevalent in this population. So if I tell you, and I put this A and the B, it's a Greek B, that means beta amyloid or amyloid beta plaques, however you want to call it. We know in Alzheimer's disease, as well as other things, which I won't go into, but one of the things that we find quite often in the brain, particularly in the temporal region of the brain, is this build-up of beta amyloid plaques. So these amyloid plaques come from something called an amyloid peptide. Next step, well, the amyloid peptide comes from your APP, which stands for your amyloid precursor protein or your amyloid protein precursor gene, whichever way you want to say it. So we've got this gene that produces amyloid peptides, which potentially, if they form into amyloid plaques, can lead to Alzheimer's disease. The gene that does all this sits on your chromosome 21, usually referred to as HSA21. Now, this is where we have this link to Down syndrome, because in Down syndrome, you tend to have a triplication of this chromosome. And there are different types of Down syndrome, and some of you who work in this particular area may be aware of this. We have trisomy 21, we have translocation, and we have mosaic, all involving some element of additional bits to chromosome 21. But 95% of all Down syndrome cases, and I've abbreviated that to a DS on the slide, 95% of cases are due to trisomy 21. So logically, this means that people with Down syndrome have an extra copy of the APP gene. This in turn then you can see will lead to an overproduction of your amyloid plaques, which then increases your risk of Alzheimer's disease. So when people say, what's the connection between Down syndrome and dementia? Why is there such a high risk? The first thing we say is the type of dementia at high risk is Alzheimer's disease. And Alzheimer's disease, one of its main causes is this accumulation of amyloid plaques. And your chromosome 21 has a big impact on amyloid plaque production. So if there's anything slightly wrong with your chromosome 21, then that could lead to those consequences. And here we talk about it specifically in relation to trisomy. So I'll just give a little breath. I'll pause for a moment because that was a science bit. So I'll just give you a minute or so just to read for those slides again, so you can digest in your brain in your own time. So I'll just give you a few seconds to read this slide. Okay, so hopefully that may ask some of the questions about this association. It's a bit sciencey, and there's a bit more to it than that, but hopefully that gives you the angle to go on. Trisomy 21, an amyloid protein precursor gene. That's the main thing to think about. Okay, so now we've highlighted there's this connection between Down syndrome and dementia. And we've also argued that it's higher in the LD population anyway. I'd like to spend just a few slides considering what is and what is not learning disability. Because there may be some of you out there who have got a good knowledge of dementia, particularly if you've attended some of your other sessions, but you're not quite sure how far or what we mean by the term LD. So the first step I always talk about, particularly when I'm talking to my students here, is what is it not? And usually we have quite a big, sorry, the software thing just came up on the computer, ignore that. So sometimes we have a discussion about learning disability versus learning difficulty. Now, learning disability is a term we're referring to. Learning difficulty refers to something quite different. And usually in the context of certainly higher education and clinical practice, learning difficulty could relate to things like dyslexia, dyspraxia, dysgraphia, dyscalculia. However, sometimes in educational settings, they will use the term learning difficulty in a slightly different way. So just be mindful about that. What we are doing is we're saying we're not talking about dyslexia, dyspraxia, dysgraphia, dyscalculia. What we're talking about is something quite different. We also want to separate this from what we call ABI, acquired brain injury. And usually that occurs in adulthood. Sadly, when people have some sort of trauma to the brain, they acquire a brain injury. That's different to learning disability. So, what is then a learning disability? Well, we have three clear criteria, and all of these three need to be present. So, the first one, learning disability includes the presence of, firstly, deficits in intellectual functioning, so reasoning, problem solving, planning, abstract thinking, judging or learning. So a deficit in intellectual functioning. Second, adaptive functioning, resulting in failure to meet developmental and socio-cultural standards for personal independence and social responsibility. So ignore the odd bracket on that word there, but it's for standards for personal independence and social responsibility. So this second element is more about the social consequences. And then thirdly, the onset of these symptoms need to occur during, not after, but some point during the developmental stage. So a long time ago, we used to say it occurred before the onset of adulthood. But then what do we mean by adulthood? And then if we go by the blanket term of 18 years, we do know some people develop slightly later and slightly earlier. And for that reason, we don't say 18 years or adulthood now. We tend to say developmental stage. But generally, if you have in your mind while you're a child, then you become an adult, it's something different. If you're still developing, then that would lead us to the idea that this is probably a form of learning disability. So intellectual functioning difficulties, social difficulties, and both of these occur during the developmental stage, and they have a long-term impact. So they're not going to go away after a piece of time. They're going to continue for the rest of that person's life. So ongoing effect. So I hope with that you've got some ideas what an LD is. You may want to, at this point, in the comments box, pop down some particular forms or types of LD that you may have heard of. And those of you working in the field of LD, you may want to pop some, we call them usually phenotypes or genetic conditions, but it'd be interesting to see which ones you've heard of or you've got experience with. So just pop those in the comments box for now, and I'll look through those on the day. I'll just give you a few seconds to do that. Okay, lovely. And don't worry about spelling. I can't spell. I mean, you've seen my slide. I can't type. So don't worry about your spelling. Right. The next thing from a learning disability we need to look at is how it's classified. And we tend to have, at the top, I've got mild, then moderate, then severe, then profound. And it's very rudimentarily based on this IQ range. We do talk about this focus on the IQ is becoming less and less. But just to give you an idea, learning disability spans quite a large area where people may have a mild LD. So their IQ range goes up to 69, 70-ish. And they're likely to result in some learning difficulties in school, but many adults will be able to work and maintain good relationships and contribute to society, but they may need support with some particular aspects. Moderate, the IQ range is slightly lower, and we're starting to see an increased need for support, varying degrees, to live independently and to work in the community. There may be some elements of self-care, but there's probably more adaptations needed to communication and support needed. Severe, likely to result in continuous need of support in many aspects of their care. And profound, we tend to also see communication, mobility, continence, etc. Needs for support. So when we talk about LD, you may hear someone say they've got a mild learning disability or a severe learning disability. This is what it tends to relate to. And my brother, who I spoke about at the beginning as a sibling, he had he would be classified, or he would have been classified as severe learning disabled in that sense. So the potential causes then, what could cause this? Well, we can split this up into three broad areas, and there's some examples there, not all, there are many more. Prenatal, perinatal, and postnatal. So prenatal, before birth, perinatal, during birth, and postnatal, after birth. So the perinatal, we've got genetics, and that's where, for example, lots of these other conditions may start to come into place. Quite a few types of LD are caused by genetics. Down syndrome is one example with your extra or trisomy chromosome 21. We've got infections, maternal health, and some physical factors. During birth, prematurity, or difficulties or problems with the labour. And postnatal, we can get head trauma, some elements which aren't treated, acquiring an infection, etc. My brother, his LD was postnatal and brought on by the whooping cough vaccine. So that was a postnatal cause of his learning disability. So hopefully by now, you've got a good idea now what we mean by learning disability. We're now going to start to move on to think about the learning disability and dementia. But before that, I just wanted to talk to you about something which is very rarely discussed. So it could be new to some of you out there, or some of you may know already. And I'll start off by saying, or posing a question to you, and pop the answer in the comments box. What age? What's minimum age to get dementia? So the minimum age for dementia. You know, it's quite common in the older person, but can other people get it? Is it just older people? So I'll just pause for a moment while you pop a number in a comments box if you don't mind. And then again, of course, on the day I'll have a little look. Okay, thank you for that. I'm guessing people have put some numbers in. I'm hoping so. So the reason why I asked you to do that was to think about childhood dementias, because when I look through the comments, I'll check to see has anyone put some lower ages in there, because children get dementia too. It's extremely rare. And I think I put at the bottom of this slide, there's over 100 rare neurodegenerative disorders linked to childhood dementia. So this slide, what I'm trying to do is get you to understand that people can have LD, learning disability, or dementia, as well as having on both. So in the first column, I've got some forms of LD that you may be aware of: Down syndrome, Williams syndrome, Prader-Willi syndrome, Cri-du-Chat. I think about 70% of all types of LD don't have a label, because we don't know what to call that form of LD. We don't know yet, but there are quite a few we know of, and that's some examples. Now, on the other side, we've got conditions that people may think is an LD, because this is occurring during the developmental period, but it's actually a dementia. And what makes it a dementia as opposed to an LD is that it is neurodegenerative. So LD, you tend not to decline with it. That is your level, and that's what you have. In dementia, it's neurodegenerative, so it will get progressively worse. So if we think back to the Latin, I presented some of the Latin at the last summer school, but if you weren't there, don't worry. De, the first letters of dementia, means loss. Mentia means mind. So if there's a loss of mind, particularly if it's progressive, then that's more likely to be a dementia. You don't find a loss of mind in learning disability. You only find that in dementia. So I hope that makes sense. Don't worry about knowing these conditions. It's just been up there to give some examples of different types of childhood dementias: Batten disease, Rett syndrome, Niemann-Pick disease, etc. What is interesting is quite often some of these childhood dementias are treated or when I say treated, supported in either LD services. So you may well have someone with Rett syndrome if you're working with children in LD, and sometimes in children's hospices as well, because as we know with neurodegenerative disorders, they're likely also to be life limiting. Okay, so just to get your head around, there are childhood dementias, but LD is quite different from them. So those of you who didn't know that, I hope that's some interesting information for you. And as a quick heads up, because people don't know enough about it generally, on the 18th of September, we do have the International Childhood Dementia Awareness Day. And I've put a little bit here that childhood dementia results from a progressive brain damage. Symptoms usually occur at around 2.5 years of age. And then by the time people are reaching or not reaching certain milestones, etc., we're finding diagnoses usually being made at the age of 4. And very sadly, half of those with a diagnosis will die at the age of 10, which follows a very similar path to people with dementia, because it is a life-limiting condition. And I put there, we have an estimated 204 deaths of childhood dementia each year, and yet it's not often talked about. So we find more about that if you have an interest in the State of Childhood Dementia 2022 report, and there's a nice scoping review, The Collective Burden of Childhood Dementia, where lots of parents and professionals got together to talk about their lived experience. And there's a link there for those of you who want to know a little bit more, or whether you want to do something in your organisation on the 18th of September. So hope that's of interest, but hopefully now you understand there's LD and there's dementia, they're separate, and we can also have childhood dementias, but that's still not the same as dementia. We've also learnt that if you have an LD, particularly Down syndrome, there's a biological reason based on amyloid plaques and your chromosome 21 why you're at greater risk of getting a dementia. So I hope that's useful. Now, I've just popped this slide on here with some very bad words and some nicer words, only because those of you looking into this in more detail will come across a host of terminology used over its history. And at last summer school, I discussed something about terminology used in dementia. This is terminology used in LD. We've got some not nice so words like mental deficiency, mental subnormality, mental retardation. And then we've got some words that we tend to use more in the present day: learning disability, intellectual disability, developmental disability, and intellectual impairment. Those are the ones you may find being used in current language by healthcare professionals, social care professionals, and in the reading. And then globally, we have a range of terms we now use. I'm pleased to say that the term mental retardation has now been dropped from American language. It was there until quite recent, but that's now gone. So these are the terms that we tend to use quite globally. Complex needs, special needs, I'm still not too sure about those two, but the rest I feel more comfortable with, if that makes sense. But complex needs and special needs, I'm not sure. But that's my personal opinion. You may have your own. So perhaps in the comments box, if you feel happy to, pop down the term that you feel most comfortable in using, just so we can get an idea. That'd be lovely. Right, so as you do that, I'll do a little quick summary of where we are so far. LD, childhood dementias, quite different. LD, Down syndrome. Down syndrome is quite common. And Down syndrome and Alzheimer's disease have a very clear connection. And there are different words we can use to describe the LD population. Some we don't like, some we do like, and the ones on the screen now are ones that you may well see out there. And in the comments box, as a group, you may have indicated some of the terms that you feel more comfortable in using. It's a very personal experience. I do get that. So let's now move on after, I guess, just under a half an hour discussing what LD is and its connection. Let's start to move on to a stronger discussion about LD and its connection to dementia. So we'll start by thinking about some of the early signs and symptoms. And I've put two columns here. The first one represents the general population, and the second, the learning disability population. And you'll find every now and then I do a reference to Down syndrome, which I've written as DS, only because it's so common, more common in Down syndrome as an LD population than anything else in LD. So in a general population, as you may well be aware, some of our early signs and symptoms are likely to include cognitive problems, orientation difficulties, short-term memory loss, and communication. And the progression follows the course as you would get with that particular dementia type. The one where we have a slight difference here is in frontal temporal lobe degeneration, where you don't start with short-term memory loss. You may start with other social or personality difficulties or changes. But generally, for the general population, we tend to look at these cognitive problems as coming in first. However, those of you working in the field of lung disability will find that's not the case. We call it atypical. A means it's not. So it's not typical, and you mostly will see non-cognitive symptoms in the first instance. And what's really interesting is in the field of Down syndrome, people with Down syndrome tend not to have epilepsy when they're born and during that initial period. However, if someone with Down syndrome starts to develop epilepsy in their adulthood, that we've seen as a warning sign, a red flag, I'm not sure what term you would prefer to use, or a trigger to suggest they may be getting Alzheimer's disease. We don't know why, but we knew, well, someone will know why. I don't know why. I don't know why. But I do know that epilepsy is certainly a warning sign that that person may well get dementia if they've got Down syndrome. Don't confuse that with all LD, because as we have more severe stages of LD, epilepsy is more and more common. So I'm only talking about Down syndrome. The first sign in Down syndrome only would be a new set of epilepsy or epileptic seizures in adulthood. We then start to see behavioural and possibly personality changes. And in many ways, those of you familiar with dementia and frontal temporal lobe, we may see signs and symptoms that you normally see in frontal temporal lobe dementia, which is not memory loss until later on in the condition. So there's an interesting relationship there. It's not a biological one, it's just something that we can see and observe. So if you're stuck on, well, how would I recognise this? Some of the signs and symptoms we see in frontal temporal lobe dementia, we may see as symptoms for general dementia in the LD population. We also note that progression is actually a lot faster as well than in the general population. So a lot of complexity there, I think we need to be aware of. And those working in learning disability services, a really important area. And also, I reflect back as being a family member. So my brother grew up at home with us. I come from a big family, 5 of us in a 2-bedroom terraced house with 2 Alsatians and a rough collie, a very crowded house. And my mum didn't want to put my brother into any form of care. He only went into care, sadly, when my parents died. He then went into care for the first time. So I'm very aware of what it can feel like to grow up in a family situation, and certainly as he went older, then I'd be looking out for some of these potential signs. So there may well be parents of someone with a learning disability watching in on this call. So I think what I would say to you is, if your child starts to develop epilepsy when they're in their adulthood, then it's important you start to think about, could this be, I'm saying it is, but could this be a early warning sign of Alzheimer's disease? Then look for behavioural changes, personality changes. Don't focus on memory loss, focus on these, and then seek support from your GP. Okay. Right. So what could happen then? How can we start our assessment? So there are two ways we tend to look at this, a reactive assessment or a prospective monitoring type assessment. So reactive is in many ways a bit late. It's better than not doing anything, but it's a bit late. And usually, and again, thinking back to the family situation, a parent may go to the GP and say, my son or daughter is not behaving in the way that they used to be behaving. They've got these behavioural changes. There may be an epilepsy if they've got Down syndrome, etc. And the GP or the healthcare provider may say, okay, let's start to assess cognition and social skills. You're reacting to the incidents in front of you, to the signs and symptoms presented. Now, what we would prefer to see in LD services is we don't wait for something to happen, we monitor in advance. Because what we want to see, particularly knowing that the presentation is not so much about memory and disorientation, more about changes in behaviour, which includes changes in performance of activities of daily living, is we need to see a clear baseline. So if I know what I'll call them ADLs, activities of daily living. If I know what your ADLs are like, and then I reassess later on and I find they've gone down a bit, I'm starting to monitor there's a clear change from the baseline happening here. If I wait until I see symptoms starting to show, I've got no baseline to compare it to. And that's really important because in LD, as we've said, it's not about memory loss. It's about changes in behaviour, which includes ADLs and skills. So we need to know what there were before, so we know a change has occurred. Now, I appreciate under reactive assessment, you may ask family members, care staff, etc., but we are relying on formative details to remember what they were like. And although they could be absolutely accurate, they also may not be. So we prefer ideally some sort of prospective monitoring. Now, when do we do this? Well, we need to show what we do precedes any onset of dementia, so beforehand. But equally, we don't want to do it too early because we want to start our monitoring at a point when the brain has properly developed. So we call that functional stability as well as brain development. And in the field of learning disability, we tend to find that usually occurs anytime between the ages of 21 and 30. So with that in mind, to give it as long as possible, we wouldn't tend to start monitoring, prospective monitoring, until they've reached the age of 30 years. Now, what I appreciate is if epilepsy comes in before then, you may start to do it a little bit earlier, particularly after their 21st birthday. So I do understand if that's happening, but we tend to say 30 years is our very clear starting point. But I would go a little bit earlier if they're having epilepsy, because we know that's a warning sign. But we be aware it could go up because they've not fully developed yet until they're 30 on the whole. So what type of assessment do we mean by this? Well, we've got a range of assessment tools we could use. And again, on the first column, some of the common assessment tools used in the general population. You may have heard of these before. There are many others, and it's not the only thing you do, but some examples of assessment tools a GP or a similar service may carry out will include the mini mental state examination or the Admiral cognitive examination. But of course, there are many others. Do not use these assessments in learning disability because they don't work. They're not sensitive enough to learning disability. Instead, we have some very particular screening or assessment tools. So those of you who run LD services, The assessment tools that will often be used are the DLD, Dementia Questionnaire for People with an LD, the DSDS, Dementia Scale for Down Syndrome, and the D-Squid, the Dementia Screening Questionnaire for individuals with intellectual disability. And my guess is, particularly if you're working in a residential home or somewhere similar, the local learning disability nurse at the GP surgery or someone will have one of those tools that they tend to use. So remember, we don't use assessment tools given to the general population because they don't work in LD. We do have a very specific set of assessment tools that are used, and any one of those can help support. So remember earlier on I said, well, don't use these tools until they're 30 because of brain development. Well, on this next slide, what I've given you is how often we do that. We talked about this, let's look in advance. So let's do a baseline. But once we've done that baseline, using one of those tools, how often or how regular should we repeat that? The frequency. So the frequency of doing the reassessment increases with age. So I put there as a note, frequency correlates with rising age-related risk. So on one side, if they're less than 30 years old, it's not usually indicated. If you do, expect the numbers to go up if the brain hasn't fully developed by then, before it starts to come down. Between 30 to 39 years, you do your first baseline assessment. And I would use as a clear indicator on their 30th, not their 30th birthday, it's a bit harsh on their birthday, but on the year that they're 30, that's when you start doing that's the year for the baseline assessment. So if there's any LD nurses out there, then as soon as they hit 30, then that's when this needs to be pushed for. People working in residential care, that's when you go to your GP. Parents, if you've not been approached by their 30th year, particularly if a person has got Down syndrome, and this is where the biggest concern is in Down syndrome, then that's when you may want to approach your GP and remind them, my child's got Down syndrome, I would like a baseline assessment, please. And fingers crossed you'll be supported. Then between the ages of 40 to 49, we do it every 2 years. But once they hit 50, because the risk is now very high, the reassessment is done every year. So if we go back to the previous slide, one of these tools ideally should be used when they're 30 and then repeated again in line with this chart here. So we're getting an idea, and we know as soon as possible when things aren't starting to go right. There are the usual things we have to think about. When you go for when a person goes for their assessment, are they well normally? So what I mean by that is they've got no delirium states, meaning they've not got an infection, they're not constipated, they've not had a recent change in medication, because all of that could affect the score. And that means we're not assessing for dementia risk and lowering of ADLs. What we're actually seeing is the consequence of having a urine infection or being constipated or medication changes. So always check. If you get the message to come in and have the baseline assessment done, just check that if you're a parent, that your child is as well as they can be. They've not gone for any recent changes. And if you're in a care home, if they're not very well, wait until they are before you do the assessment. So I hope that makes sense. So what else could be included in this assessment? Well, we'll need a detailed history, always a physical examination to rule out things like delirium, so constipation, medication changes, etc. Infections. And also, again, I keep talking about Down syndrome because it's so common, a thyroid function test. Hypothyroidism, so I've put that in that sentence there, the third bullet point, hypothyroidism, that's an underactive thyroid gland. The symptoms are likely to mimic the symptoms of dementia. And therefore, if people just think Down syndrome, amyloid protein stuff, trisomy 21, oh no, I think they've got Alzheimer's disease. But actually, it might be they've got an underactive thyroid gland. So we must get that tested first. So a thyroid function test is, I would say, essential. Essential. We can do a mental health examination, which includes things like depression screening. Again, in Down syndrome and in other forms of LD, depression can be quite prevalent. And all the symptoms we're seeing, depressive symptoms as opposed to dementia symptoms. We're trying to avoid diagnostic overshadowing. So on the day, if I remember, I'll try and type that in the comments box. Diagnostic overshadowing. That just means you've got one idea in your head, dementia, and all the things you see must be dementia. It's diagnostically overshadowing everything else. We need to avoid that. So we have to check, is this depression? Is this an underactive thyroid gland? Is it down to a medication change or an infection somewhere? All this needs to be checked. We can look at the environment. We can look for a sensory assessment. Again, in Down syndrome, because we have the epicanthic folds and cataracts and so forth, then the behavior pattern we're seeing is that their experience of some degree of sensory loss. So sensory assessments are usually carried out. And then what's typical in the general population is some sort of neuroimaging may take place. CT scans, SPECT scans, MRIs, etc. Now, we don't tend to push that in learning disability because that will show, and I've written at the bottom there, temporal lobe atrophy. Temporal lobe are these lobes at the side of your head. And inside your temporal lobe, you have something called a hippocampus. And that's where Alzheimer's starts. That's what it's looking at. And atrophy means shrinking. So these scans, particularly if you're looking for Alzheimer's disease, will look particularly at the temporal lobe and see, is there any shrinkage occurring? And if so, that could be a sign of Alzheimer's. However, we know in some forms of LD, particularly Down syndrome, we will have atrophy or shrinkage of your temporal lobe anyway. And therefore, it could give us a false reading. The only time I think it's a good idea is if you think you're having other symptoms and you think, what if this isn't dementia? What if this is down to a brain tumor? Then, of course, some form of neuroimaging may pick up on that. So you're not using it routinely, but the doctor may indicate there are other symptomology that may suggest, is this brain tumor potential, and then do a neuroimage, not to look for atrophy, but look for brain tumors, if that's the case. So what are some of our next steps then? Well, there's a faster progression, so please be prepared. Epilepsy management, particularly if you're not used to the person having epilepsy, then it's understanding what to do when people have an epileptic seizure. Dysphagia, that means difficulty in swallowing. As the dementia progresses, swallowing difficulties may increase. Managing incontinence, communication, advanced care planning put in place, risk assessments, thinking how you're going to alter your mental capacity assessments and understanding risk. And some of the documents that may be helpful if you've not got those ready for you yet, within your service include epilepsy record charts, dietary plans for dysphagia and difficulty in swallowing, having without doubt an advanced care plan in place, your OK health check, health action plan and community passport. So people used to LD services may be well aware of OK health checks, health action plans, communication passports. If you're not used to LD services and you're new to it, then these are things you need to be familiar with. But please don't forget the advanced care plan. So we're almost coming to the end now. So I hope that was useful. I'll just give you a moment to reflect. I've chatted quite a bit. I've only got a few more slides to talk you through, and I call these pause for thought slides. So essentially, based on what we've discussed, I'm just going to pose a a statement or a question for you. And then if you feel happy to put something in the discussion box, or we can wait and have a discussion with me on the day. So based on what we've said so far, here's my first pause for thought for you. Firstly, people with an LD are not always told I think I forgot the word have there. People with an LD are not always told they have dementia. What are your thoughts? Because it could be a school of thought saying, well, they need to be told. That's their right. And another thought could be, but if we tell someone who've got dementia, could that make them feel more anxious? Could it bring on depression? And then equally, well, how would I tell them they've got dementia? So it's an ethical, legal, professional, and you could also argue, well, it depends on the person, etc. Once you tell someone, you can't take it back. But if you don't tell someone, are you hiding anything? Do they right to know? So I'll just give you a very brief minute to jot down anything you want to in the comments box if you feel comfortable, or we can have a chat about it on the day. So I'll just give you a minute. Okay, another pause for thought, and don't worry if on the day you've not quickly typed it all out, because I'll be there on the day and we can raise that. We may pull up these slides and do these on the day itself, which may be a little bit easier. So here's your second pause for thought. For people in shared living with other people with an LD, should their dementia diagnosis be shared with their peers and housemates? Your thoughts on pros and cons, legal rights. What I mean by that is, let's imagine a supported living or group home. There's 4 people living in this house with a learning disability. One of them now has a dementia diagnosis and they are behaving in a different way to what they did before. And for the other housemates, they're getting a little bit cross with their housemate. So, should you tell them that their housemate has got dementia, or should you not? We can look at how you tell them on the day, if that's the course of action you want to go down. But there's a big issue here. Have you got consent from the person to share their diagnosis? Do they have a right to keep that secret? But then if you don't share it, are they going to be vilifying that person because they don't realize they can't control what they're doing? So I'll just give you a minute or so to think about that. And again, on the day, we can discuss it in a bit more detail. Should you share the dementia diagnosis with housemates? Okay. And then as the final slide and the final pause for thought, as you know, in this summer school, I think you talked about on one of your very first sessions about Dementia UK and the Admiral nurse and what Admiral nurses do. So I wanted to end this session really with if you are a parent of someone with an LD, if you have LD yourself, if you are working with people with an LD, then based on what we've discussed so far, how can the Admiral nurse support you? Because that can give us ideas and suggestions for our own development and service development, etc. So we know what type of support you would feel would be useful for you. So I wrote down there, be great to hear your thoughts on what you expect the Admiral nurse could offer. And if we reflect back on what one of the key roles of an Admiral nurse is to support carers of people with dementia. So if you're the carer, and that could range from being the parent, it could range from being a relative like myself, being a sibling, it could be the residential care staff, could be a GP, could be another professional. and you had a client or a relative with a learning disability and dementia, how can we support you better? What would you like us to help you with? And that's a really important thing to do, and something that we can take back to Dementia UK, and particularly those working with LD services and LD support. So a very important element, I just want to give you a few minutes to write some bits down that we will be taking forward in some way. Okay, I'll leave it there because then at the day you may want to raise your hand and talk out some of the bits and we jot them down together. But in summary, yeah, if you go back to our very first slide, what we've looked at is what is a learning disability. We've looked at the correlation between LD and dementia, and particularly why people with Down syndrome are at a higher risk. We then looked at the difference between LD and children who got dementia, and just pause for a moment to talk about childhood dementias. And then we went back into, okay, so if I've got LD and I've got dementia, how is that assessed? And what sort of things should I be thinking about? And then we've moved on to some of the support that perhaps an Admiral nurse may be able to provide you with if you were lucky enough to have access to an Admiral nurse, or equally within the community, what sort of resources can we start to develop to help you a bit more? So I hope that's been useful, and I shall see you on the day. I think we'll start by presenting this, and then it'll cut off. You'll then see me, and we can have a jolly good chat on anything that we've spoken about you'd like a bit more detail on, or any questions. And I'll very much look forward to looking through the comments box on some of our pause for a thought or questions I pose to you. So you all get something from this session, and that it's been of some use. Okay, so thank you all very much, and I shall see you on the day. Thank you.